And we have Jeff Meyer?
Yep.
Okay, I'm sorry about that. For some reason, I think differently. So Jeff Meyer, he is our consultant pharmacist, and we are now working with Avera Long-Term Care Pharmacy. And let's have a shout out for Avera because they're pretty awesome. Woo! All right, so they're both going to come up now and they're going to present on restraints.
Good morning, everybody. This is really hard to talk to such a large group. Jeff and I were talking, it's like, we're thinking a smaller group, but here it goes. I'm going to be just talking about physical restraint, and mine is just real quick. Does anybody know the definition of physical restraint?
Stop somebody from doing something.
There it is. Okay, and the physical restraint, it says it may be a physical device or equipment which is attached to or next to the patient's body that he or she cannot remove easily. Could you please tell me what are some of the restraints?
Lap buddy?
Lap buddy. Anything else that you can think of?
Recliner.
What kind of recliner?
Kind of goes all the way back and then get out of.
Kind of like a jerry chair.
Yeah, chair.
Okay.
Mary walkers.
Yep. Any
Wheelchair.
lock wheelchairs?
Body to body restraint. Holding.
That's good.
Eye down.
Yes. But thank God we have gone away from all that, from the physical restraint that we used to have, like the vests, the mittens, the side rails, we no longer use. But also another restraint would be, like they said, locking the brakes. When they're not able to unlock it, that would be a restraint because we're using it for our convenience, not for the rest of them. Another one would be in a recliner, those electric recliners. If they're able to walk a little bit and if you're putting them up and taking away the electric remote, that is also a restraint. And if we do that, we have to do assessments, we have to show why we're doing it. So we have to let them have the remote to where it's close to them. Another one that we don't really think about.
Medication.
Yes, and he's going to talk about medication. That would be with the chemical. But another one would be that is very much that sometimes we forget not to do is the call light. When you don't put that call light where they can reach it, you're restraining them from getting help. So that's one of the things that we really got to focus is putting that call light. When you leave, that they have access to that call light, right? And then we know what are some of the psychological effects that it has when you restrain them. Some of them are, they're agitated, they're hostile, aggressive, they can become combative. I know when we put them at the table and we lock the brakes, they want to move, right? And none of us would like to have a restraint, right? And some of the physicals that we noticed that they used to have when we used to have the restraints was pressure areas, ulcers, skin trauma, bone loss, and also decrease in muscle mass. So we are so glad that we have gotten away from using all those physical restraints. When I started at Bethany, every bed had a side rail. And when they took them all off, believe me, we were all scared. Oh my God, I thought, no, how are we gonna do this? But in reality, guys, it has become much better. I mean, yes, some do fall, but the beds are lower down. And if those electric beds, if you take that remote away from them to have access, that is also a restraint. So make sure that remote is close by them, right? So, people do get scared when we have taken the restraints, but in reality, studies have shown that it has helped. That residents are much happier, and we have come up with better things to help them out. So we no longer use physical restraints. We try to do other things. A nurse can get a physical restraint order or use it in an emergency basis only, but they have to prove that it's an emergency to that individual's life. But other than that, we do not use restraints. We try to find alternative motives, things to do, like walking them, finding what they like, and then finding them, like if they're music or if they're being too stimulated, we gotta find other things to do for them, right? So, any other questions on physical restraints? So I'm glad we have gotten away from it. So I'm going to let Jeff come over and talk about chemical.
Hi everybody, how are you doing?
Good.
Alright. Well, I've not gone through this yet. I have to go a little fast to get you guys caught up again here for you. Like Deb said, I'm Jeff Meyer, the consultant pharmacist for Bethany. I've only been here a couple of months. Knowing you guys, knowing you residents, so it's been great so far. And like Ray said, I'm going to talk about chemical restraints just really quick. I'm going to go over the definition. I'm going to go over the classes of chemical restraints, side effects of chemical restraints, and I think that's important just because I'm also going to get into documentation is important. So in order to document, you need to know what the potential side effects of each chemical restraint can be. So then if there is something that needs to be documented on any form or anything that needs to be corresponding to the physician, you guys are aware of some things that you should be looking for. So again, nice and easy. Medication used to control behavior or restrict the patient's freedom of movement that is not standard treatment for the patient's medical or psychiatric condition. Chemical restraint, any drug used for discipline or convenience that is required to treat medical symptoms. And discipline, anything in purpose of punishing or penalizing a resident. And then convenience, basically taking care of the behavior with a lesser amount of effort by the facility and not in the resident's best interest. And that's kind of the big thing that we have there for you. Use of chemical restraints, big things that you want to look for. Acute danger to self and or others. Are they harming others? Are they are they trying to exit seek and they're going to be out by themselves and no one there to assist with them? Is the danger immediate and apparent? Other treatment options did not work, so we are now using the chemical restraint as a last resort. Again, something that should be documented that it was kind of the last resort. Again, not to be used as disciplinary measure. And in red, this was done by my boss, so he must have thought it was relatively important. All these must be documented, and then the last thing, can it be quantified? One thing that he used here was exit seeking. He's like, you can quantify exit seeking. The exit seeking 2 times a day, we have a number then for you, and then you're ultimately using a chemical restraint. You can then quantify if you have a benefit. Exit seeking is down to once a week as opposed to twice daily. So just other stuff that you need to look at when you're thinking about chemical restraints. Because the thing from this that we wanted to specify was documentation. It covers yourself and the facility the best. So just going into the medication classes then, your antipsychotics, antidepressants, anxiolytics, mood stabilizers, sedatives, and hypnotics. And I'll go into each one of these here for you. So you have the antipsychotics. I tried to put in most ones that you guys have seen, maybe a few that you haven't seen. I don't know how many of you have seen fluphenazine or buciprazole a lot. As far as first gens go, haloperidol is probably the most you see quite a bit. And you're usually seeing that a lot of times with hospice. It's one of the hospice orders that you see quite a bit. The second generations, that's really what you're seeing mostly of, I would say now. Probably the biggest ones I see would be Seroquel, Zyprexa, and Risperdal. Geodon being a little older, you don't see that one so much, and Latuda being the newest one added to that list. At any time, if you guys have questions, raise your hand. I'll answer anything you guys want. So going into these big things that you want to look at, these guys are very effective antipsychotics, very effective for sedation and acute agitation. So that's why I started off with these guys first. But definitely side effects you need to watch for 100%. QT prolongation, you guys know what Forsage is. It's a lethal ventricular tachycardia that you can get. There's a black box warning on it. Very serious. Always something to be concerned about when utilizing any antipsychotic in residents. Orthostatic hypotension, the reason why that's important, increased risk of falls with the population we have. Falls has to be one of the biggest things that we're always concerned about, and metabolic abnormalities. So we're looking at, in my notes, you'll see me asking for certain labs on somebody that, they're not on levothyroxine, they're not on lipids, and they're not diabetic, but I'm still asking for an A1C lipid panel and a TSH, because these can affect all of those and we kind of get them out of whack. Also, weight gain is huge. Like you said, Zyprexa, you think of weight gain a lot. So with weight gain, you can get increased lipid, you can get type 2 diabetes, ultimately colon, so you're looking at that stuff. And extrapyramidal symptoms, tardive dyskinesia, dystonia, akathisia, And this is why we're doing those Ames assessments every once in a while. Ames or discus. Discus is just another way of, is very similar but different test for that. That's why we're looking at those. They got to be done every 6 months. A lot of facilities, and I believe you guys do them quarterly, which is always good. And anytime there's a large dose increase, that should be also something we're looking at as an Ames assessment to be done at that time to watch for any increase in movement. And then of course, sedation is huge. Antidepressants, you have the different ones, SSRIs, SNRIs, dopamine, norepinephrine reuptake inhibitors, tricyclics. Tricyclics are big, very anticholinergic side effects with these. We get anticholinergic side effects, again, risk of falls, everything like that goes with that. And then you just kind of have some other ones, trazodone, mirtazapine, which you see quite a bit. And these actually, I follow putting them in hypnotics because we see these a lot of times for use for anxiety. So it's just going to be something that you have on that. And again, what we're looking at on side effects, nausea, appetite, weight gain, that would be like a Remeron one. Fatigue, insomnia, dry mouth, blurred vision, constipation, especially there you're looking at anticholinergic side effects. So tricyclics would be a big one there. Dizziness, agitation, irritability, anxiety. Another one, just to step on, look at that constipation one. If you are seeing somebody just put on an antidepressant and all of a sudden they went from needing loperamide all of a sudden to now you're talking to the doctor about constipation, something to look at. You know, are you noticing that, and are they, you know, what has changed in their medications to where all of a sudden they're now dealing with the opposite of what they were? Definitely something to look at. So then we get to anxiolytics, sedatives, hypnotics, kind of put it all in one here for you. So on the side, going all the way down to chlorazepate, you have your benzodiazepines, something to look at, buspirone, just a different type of anxiolytic. On the right-hand side, you have all your hypnotics, your Lunestas, Roserum, Sonatas, Vulcan, Balsama. And I did put diphenhydramine on there also, just because that is definitely used as a hypnotic. It's on the Beers list as something that we don't want them to use. A big thing on that is like the hangover effect. So just something to think about. And also I was going to bring this one up too, just since this would be the epitome of a chemical restraint. Have you guys ever heard of a B-52 bomber that they've utilized? It's 3 medications. It's Benadryl, it's Haldol 5 milligrams, and it's alprazolam 2 milligrams. So that is something, I did a 5-week rotation at the Behavioral Health. Little 5'4" lady needed 2 of those shots at 11 o'clock at night. She slept until 3 the next morning. Usually 1 will take a person out. She required 2 of them. So it's just something like that. So that's 3 things. I mean, it hit your antidepressant, it hit your anxiolytic, and it hit your hypnotic. I mean, that's in one. So it's just something to think about when you're looking at what an actual chemical restraint could be. So side effects, respiratory depression, we're looking at that. Hypotension, again, risk of falls with that. Somnolence, hangover effect, like I said, with benzodiazepines and your diphenhydramine is a big one you're looking at. Dizziness and falls, especially with alcohol. I know a lot of times we'll see, PRN wine, beer at night, something like that. Just something to think about if you're on something like this. That's something else that we really want to be watching for. Mood stabilizers, Depakote, lithium, lamotrigine, carbamazepine. Lithium, of course, you see quite a bit. The other one you can see for seizures and everything. Depakote and lamotrigine, though, are there also for you. Nausea, vomiting, diarrhea, trembling, increased thirst, increased need to urinate, weight gain in the first few months of use, one thing to watch out for, and drowsiness. All right, so now we've got all these classes that we're looking for, and then every month you get an annoying pharmacist that comes. You have a patient that's on it that seems like they're doing great, and then this guy all of a sudden asks for you to decrease an antipsychotic. And the reason is because it is literally my job. CMS stipulates that if we don't do this, you guys get an F tag, and we don't want that. So this is what it is. So antipsychotic drugs receive gradual dose reduction and behavioral interventions unless clinically contraindicated. Every one of my notes asks unless it's contraindicated to not do it. In an effort to always discontinue these drugs. So they want to, as long as they're having symptoms, they want, the medication's there for them. The moment they're not having symptoms, they want to have an effort to try to get rid of them. Because I do struggle with antidepressants being listed here as a chemical restraint. A lot of times we're not using one as a chemical restraint, but if their PHQ-9 all of a sudden has been 0 for a year, and they're still on 40 milligrams of Prozac, which is up with potential side effects, that's where I can see that's how it's really ultimately listed in here for you. So something like hypnotics, anything like that, anything used for insomnia, it's got to be quarterly. It's got to be addressed either in the progress note or through a note from your pharmacist. Psychotropic meds twice in the first year and then annually after that. So we get down to the most important thing. We really got to get into the documentation. Accurate documentation of the restraint episode is vital to safe, effective patient care and provides information that can improve the quality of care. What did you try? Was it effective? If not, there's no need to try it again. You know, if it didn't work, move on to the next thing. That's kind of the big thing from there, and they can improve the quality of care. Was there a physician order? The B52 example I gave you, there was an order for that. Or if you guys need an order for anything out of the E-kit, you know, we have Zyprexa 10 milligram injection. That's in our E-kit for you guys. We have lorazepam also. That's in the E-kit for you. That's that one, physician order, pull it out of the E-kit, take it. And then document the need for the chemical restraint. You know, what behaviors they have, what's their mental status, are they orientated, you know, and exactly how are they. So it's just something to look at. The more you document, the better it kind of covers yourself. And then document failed non-medication interventions. What's their trigger points and everything like that? Can you take away the trigger? Can you do anything to alter that? And to try everything but this. And again, like I said it earlier, the chemical restraint just to be done last. A review of the patient's physical and mental health status. This is once you give the chemical restraint, documentation is not over. That's where you should document how are they taking the medication, blood pressure, heart rate, anything like that, with lethargy. Continue to document to see how they're utilizing it and taking it. An assessment of the adverse effects of the medication, reassessment of the medication prescribed, and then assessment of the risk to the patient from deliberate or accidental self-harm. You know, is it going to be an increased risk of falls now that they're on this medication? Assessment of the potential or likely need for a repeat application of chemical restraint. Do they need another B52 shot? Did it work and can we quantify it? And again, that being able to quantify it is huge because that is the one way to, you're really looking at the surveyor, that's the way to prove to them that it was successful and it was for the need for it. Again, exit seeking. Twice a day down to once a week, success. You know, so this is something to look at, and then that's it. Any questions or anything you wanted me to cover that I missed? I can try. I have to be honest. I had my presentation set, and I just saw those questions a little bit ago. Is there a copy of it? All right. Or do you have questions on any of those, or?
I do on number one.
Well, there's a lot of these are physical. Do you want to do the
I
physical?
have a question.
Yes.
Oh, good.
Sorry about that. I'm very focused here.
I know, you are, that's very good. Little affirmation there. My question is, using, you know, like antidepressants or whatever for anti-anxiety medication as a restraint, I can see that that's not appropriate. But there are times when those are necessary for quality of life.
Sure. Oh, yes, absolutely. Yep.
Okay.
So that's where I said, you know, using antidepressants, fine. The PHQ-9, the one thing we use in the MDS. If that's, you know, if that's an I, that's an 11, that's a 15, absolutely. It's when, you know, quarter after quarter we're looking at the MDS, and it's a 0, and it's a 0, and it's a 0. And they're still on, you know, a very high dose
Okay.
of that. That's where it's like, you
So
know.
then there's a need for adjustment.
Right, yep, yep. Can we, you know, can we try? Can we just go down to 30? Can we try at 20? See that? And then if the PHQ-9, then the next quarter, you start seeing it creep up, then we know that that's where it's at, and then you start looking at it yearly, and you address it with the physician. If he says, patient currently stable, has had long history of repeat severe depression, depression, however he wants to state it, then that's all we need. Just